Hello everyone, welcome back. Today I'll be covering regarding the management of open fractures of the lower limbs, adapted from BAPRAS, a British Association of Plastic Reconstruction and Aesthetic Surgeons. A part 1 video. I hope it helps. Thank you. Now let's get started. As an introduction, open lower limb fractures often associated with high energy trauma, and the initial evaluation and treatment of the patient must occur simultaneously. The following steps: Number 1. Airway with spinal control, breathing and circulation based on ATLS principles. Number 2. Stop the external hemorrhage by direct pressure or as a final resort, application of a tourniquet. Number 3. Neurovascular examination of the limb. Number 4. Adequate analgesia. Number 5. Straighten and align the limb. Number 6. Repeat the neurovascular examination every after procedure. Number 7. Remove the gross contaminants from the wound. Number 8. Photograph the wound so you don't need to open up the wound every time. Number 9. Cover the wound with sterile, moist saline dressing and adhesive film dressing. Number 10. Leave the wound undisturbed until patient reach the operating theatre. Number 11. Splint the fracture if it's not done. Number 12. Repeat the neurovascular examination. 13. Intravenous antibiotics. Co-amoxicillin 1.2 gram or cefuroxime 1.5 gram every 8 hourly or clindamycin 600 mg if the patient is allergic to penicillin. 14. Check the tetanus status and administer prophylaxis if required. Number 15. X-ray. 2 orthogonal views. 2 joints. Repeating neurovascular examination after each intervention and record it. What is the timing of surgery in open fracture? The only reasons for immediate surgical exploration are the presence of A. Gross contamination of the wound. B. Compartment syndrome. C. A devascularized limb. D. A multiple injured patient or polytrauma patient. Harley et al. Found no increase in deep infection or non-union rate in patients who underwent debridement up to 13 hours after the injury. The strongest predictor of deep infection was the grade of the fracture. The most important factor in reducing infection was the administration of broad-spectrum antibiotics. The LEAP group found that delay over 6 hours and up to 24 hours had no effect on outcomes, including infection, time to union, non-union rates, number of surgical procedures, admission, time in hospital, time to weight bearing, walking speed, and time to return to work. Guidelines for wound debridement. Early, accurate debridement of the traumatic wound is the most important surgical procedure. Debridement means excision of all devitalized tissue, except the neurovascular bundles. Traumatic wounds are excised completely and systematically and following sequence. 1. Initially, the limb is washed with a soapy solution and a tourniquet is applied. Number 2. The limb is prepped with an alcoholic chlorhexidine solution, avoiding the open wound and pulling under the tourniquet. Number 3. Soft tissue debridement or excision is performed under tourniquet. This allows identification of neurovascular bundle which may be displaced and permits accurate examination of tissues. 4. Visualization of the deeper structures is facilitated by wound extension along the fasciotomy lines. The tissues are assessed systematically from the superficial to the deep, skin, fat, muscle, bone, and from the periphery to the center of the wound. Non-viable skin, fat, muscle, and bone are excised. 5. The 4 C's. Color, make sure it's pink, not blue. The contraction, consistency, whereby the devitalized muscle tears in the forceps during retraction. And the last C is capacity to bleed. Number 6. At this stage, the injury can be classified and definitive reconstruction can be planned properly. 7. If definitive skeletal and soft tissue reconstruction is not to be undertaken in a single stage, then a vacuum foam dressing or antibiotic bead pouch if there is significant segmental bone loss is applied until definitive surgery is performed. Bone management. 1. Extension of the traumatic wound is along the nearest fasciotomy incision. 2. A bloodless field during soft tissue debridement is helpful. Deflating the tourniquet before the bone debridement allows satisfactory confirmation of a capacity of the bone ends to bleed. 3. Careful surgical delivery of bone ends through the wound extension aids the circumferential assessment. Number 4. Regarding bone debridement, visible dirt and particulate debris should be removed using a forceps, curettage, a scrubbing brush, or occasionally bone nibblers if dirt is embedded within the bone. A layer by layer or compartment by compartment approach is used. The process is interrupted with periodic irrigation and suction to maintain visibility. This figure shows the bone nibbler that can be used for the bone debridement. Loose fragments which dislodge or separate easily by applying a steady and increasing pull. That means fail the tug test due to flail or no soft tissue attachment. Larger fragments should be inspected for fracture age or cortical bleeding. If this is uncertain, a hypodermic needle inserted into the soft tissue attachment of the fragment should produce bleeding. If not, the fragment may have a structural soft tissue attachment but without a blood supply and is likely to become necrotic. It is best to remove. Fracture fragments cannot be regarded as bone graft. Necrotic fragments and avascular ends do not contribute to fracture union and serve only as a nidus for infection. The exception is those fragments of bone with areas of articular cartilage that is large that contribute to articular stability. Such fragments should be thoroughly cleansed with scrubbing, curettage, and lavage prior to reduction and with absolute stability. If absolute stability cannot be achieved, the bone fragment will not revascularize and risk of becoming a focus of infection. The capacity to bleed, seen as a punctured ooze in viable fracture ends and exposed cortical surface, the Paprika sign is helpful, but the extent of periosteal stripping and quality of facial or soft tissue connections also contribute. It is important that bleeding from the medullary canal is not mistaken for viability from a strip fracture ends. In general, non-viable bone fragments or those in doubtful viability should be removed. Appropriate to resect non-viable fracture ends until bleeding bone is seen. This figure illustrates the Paprika sign, a punctured ooze in viable fracture ends and exposed cortical surface. In regarding the bone management, number 5, the lavage. Lavage is not a substitute for meticulous removal of particulate foreign material and non-viable bone and soft tissue. Lavage should begin after the wound appears clean. Regarding the high-pressure lavage, although this is effective in clearing surface contamination of bone, inoculation of dirt and bacteria into the soft tissues and bone has been demonstrated, along with the damage to the microarchitecture of the bone itself. They are also impaired in fracture healing. Cleansing metaphyseal bone with a surgical scrubbing brush is as effective as high-pressure pulse lavage, but without the risk of iatrogenic seeding. The addition of antiseptics, soap, or antibiotics to the lavage fluid has not been shown to add any advantages, but does carry the small risk of anaphylaxis for the latter. BAPRAS recommend low-pressure lavage with large volumes of warm saline to complete the debridement of the bone. Yay! We have reached to the end of this video. See you in the part 2 video. Take care and bye.